Good evening and welcome to Global Healthcast, brought to you by Global Health Press. In this podcast series, once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. I am Joe Schmitt, and with me, as always, is Dr. Melvin Sanicas. Good afternoon, Melvin, and welcome to Switzerland.
Yes, good evening, Professor Schmidt, and good morning, good afternoon, good evening to those who are watching or listening to us.
Yeah, we are a little bit out of date because I am recording from Singapore today, and Melvin is in Switzerland. So, welcome to Singapore/Switzerland. What we talk about today is WHO pandemic treaty talks end without a deal. And Melvin will also cover antimicrobial resistance, a growing and unevenly distributed threat to global health. He will present existing interventions that can have significant impact in low middle income countries. I will cover nicotine fade out by date of birth. I will cover TBE in Switzerland with new recommendations and the negative impact of PPV23 revaccination. But let's start with WHO pandemic treaty talks.
Yes, so the pandemic treaty refers to a proposed international agreement aimed at strengthening global health systems and really improving preparedness and response to future pandemics. And this initiative was driven by the need for a more coordinated and cohesive global approach to managing health emergencies, of course, following the challenges highlighted by the COVID-19 pandemic, right? And so the treaty has a lot of objectives. So, again, to strengthen international cooperation, to enhance surveillance and reporting, equitable access to vaccines and treatments, building resilient health systems, which has been really a part of the WHO's goals even before the pandemic. And last but not the least, one of the objectives is really addressing the root cause of pandemics. So this is looking at zoonotic diseases, zoonotic spillovers, and antimicrobial resistance as well. So it was not, it, the members of the World Health Assembly did not agree, basically, and there are several reasons. Some countries were concerned that the treaty might impinge on their national sovereignty, giving international bodies too much control over their domestic health policies. Different countries have varying economic and political interests that might affect the treat that might be affected by the treaty's regulations. And of course, ensuring compliance with international agreements can be challenging. And some countries think that they don't want to be part of the agreement because they have reservations about the mechanisms for enforcement and accountability. And also, there were several countries from the developing world that felt that this current pandemic treaty is not fair. Basically, they're talking about equity issues. So I think while the pandemic treaty was not approved by the most recent World Health Assembly discussions, negotiations are ongoing, and they believe that this could be amended and approved in the coming years.
So it is still under discussion. It
Yes.
was not signed, but efforts are ongoing.
Hmm. Yep.
Okay. Look, in
That's
the
right.
end, there are 193 countries in the world, according to what I found at some point not too long ago. So if you want to have a treaty with two or three people, it's already difficult, but with
Mhm.
193, it is almost impossible.
Yep.
So it's a shame, but maybe something happens in the near future and they may align on something. Yeah. Melvin, you have a second topic on antimicrobial resistance, which is also a at least in part vaccine preventable. What's the message here?
Yeah, so each year, an estimated 7.7 million people die with bacterial infections that are considered to be because of pathogens that are um, resistant to the antibiotics and antimicrobials that we have at the moment. So this is really a big global health problem. And rising antimicrobial resistance has been documented over the past 2 decades, and projections from high income countries predict resistance to third-line antibiotics, basically the last resort drugs, could be 2.1 times higher in 2035 compared to 2005. And this is basically a series by The Lancet highlighting that although AMR can affect anyone throughout the life course, the very young, the very old, and the severely ill, or those who are immune compromised, are the ones suffering the most. And the series also addresses how a rethink of drug development is needed to support investments in antibiotics, diagnostics, and vaccine development according to the burden of infection and resistance. Lower drug development costs will also make antibiotics more affordable and accessible to everyone. And finally, the authors argue that the need of targets to trigger political commitment and accelerate progress in addressing AMR is really key for this problem to be solved.
You did not mention one argument from my view, um, which is overuse and misuse of antibiotics. Wouldn't that be, so to speak, the first line of activity to say reduce wrong use of antibiotics and then look for everything else, use vaccines accordingly? I mean, there are many steps we can already do today.
Yes, and so on the next slide, you will see basically the top three actions that can be taken to help mitigate this problem. And as you mentioned, the first one is really promoting rational use of antibiotics, right? So really, the prescribing practices should be changed. Healthcare providers should adhere to guidelines for prescribing antibiotics. And this really involves ensuring antibiotics are only given when necessary and that the correct type and dose are used. This also includes public awareness, educating the public about the dangers of misuse and overuse of antibiotics, and also antibiotic stewardship programs. So, implementing antibiotic stewardship programs in healthcare settings, in hospitals, in medical centers, this can really optimize the treatment of infections and promote appropriate use of antibiotics. The second pillar is really improving infection prevention and control. So, really looking at hygiene and sanitation, um, and including both healthcare setting and including both healthcare settings and community environments. Also, vaccination. As you and I know, vaccinations can really prevent diseases that might otherwise require antibiotic treatment. So, you are reducing the incidence of infections and the subsequent use of antibiotics. And the last but not the least is really investing in research and development. So developing new antibiotics, developing alternative therapies like bacteriophages, for example, probiotics and immunotherapies, and also diagnostic tools. This is something that's more often than not um, being forgotten because it's important for the global public health community to really invest in advanced diagnostic tools that can help healthcare providers quickly and accurately diagnose infections so that the appropriate antibiotics are used only when necessary.
Yeah, all very good points. What I worry about is coming up with new interventions, new antibiotics, phage therapy, whatever it may be, to reduce antimicrobial resistant strains. That will not be cheap interventions, and
Mm,
they will not easily and immediately be available to the poor countries in the world.
yes.
So I guess what you have on the slide here is the highest priority, and the research and development of new interventions is something for the future, at least for most humans on the globe. Yeah,
Mhm. I mean, that's why in this slide, really aligning the infection prevention and control standards and access to wash services, they're actually top two. As if you compare it to really, for example, high priority pediatric vaccines, right? So the top two really are aligning
yeah,
on IPC standards and access to wash services.
yeah.
Yeah.
And if you add up these numbers, that's roughly 800,000 people lives prevented from dying. So that's already
Yeah.
quite some achievement if that would happen.
Mhm.
Very nice. I have one interesting thing which is not infectious either, but I like the approach, and it is about nicotine fade out by date of birth. As you know, smoking is the leading cause of preventable diseases, disability, and death in the United States, and I guess in many, if not most, countries of the world. Smoking kills more Americans than HIV, drug overdoses, alcohol, motor vehicle crashes, and firearm-related injuries combined. Brooklyn in the United States is a city with a policy that aims at creating a tobacco-free generation by date of birth, which means as of a certain date of birth, you're not allowed to smoke. The concept of a birth date-based phase-out of commercial tobacco has been proposed elsewhere. And actually, first in New Zealand in 2022, there was a similar law, which, however, subsequently, due to a government change, was repealed. Under discussion, this is also in the European Union, in the Philippines, in Singapore, Malaysia, Australia, and in Norway. Finally, this bill, there is such a bill in the United Kingdom, and it received a strong support in Parliament. The Brooklyn bylaw applies to all nicotine products, and what is debated if it should include e-cigarettes. New Zealand's repealed law and the UK bill cover combustible tobacco products only reflecting ongoing public health discussions about the relative harm of these vapes as compared to cigarettes. So there is some debate if e-cigarettes should be included. My private opinion certainly is it should, right? Once you start it, you do the whole thing and you don't stop halfway. Again, the background is less the immediate health effects or immediate prevention aspects, but apparently vapes are the key driver of initiation of nicotine use among adolescents. So the hope is that if you stop e-cigarettes as well, these adolescents will not become smokers later on. Melvin, any views on nicotine?
Yes, I think it's a difficult topic because if, for example, for me, when I travel here around Europe, I always see a lot of promotion being done for e-cigarettes everywhere I go. Switzerland, France, Germany, Italy. And so at the moment, it will be a difficult fight, I would say, if this is the goal.
Yeah. I think the concept, it was new to me, and this is why I have it here. And it is like, I mean, vaccination is combined with a date, right? You have a date in your life, and that's when the vaccine is given. And I guess this is sort of a little bit similar with this tobacco law. You have a date in life when, for that birth cohort, and later, no smoking is allowed. And I really like this, and I would personally support it, but there may be people with other views, particularly if they're smokers, right?
Mhm.
Yeah, I don't smoke. I did smoke when I was much younger, but did you ever smoke, Melvin?
No,
Really? You come
no,
from the Philippines. This is a country where, remember, there were a lot of smokers, so this is
no.
quite good.
Yeah.
Excellent. All right, I have news on TBE from Switzerland. The licensing authority, BHE, and the NITEC, EKIF, they changed their recommendations for TBE in April 2024. And the recommendation is that as of summer 2024, Geneva, the canton, is now regarded as a TBE risk area. And this means that except Ticino, now all cantons in Switzerland are considered risk areas. And to be an honest person, I can say I would think that Ticino is a risk area as well. And I'm not sure why this is not labeled as a risk area, but that's my personal opinion. TBE vaccination is recommended for all adults living in or traveling to TBE risk areas. The pediatric recommendation has also changed. It is used to be licensed for children, or the license is for children as of 1 year of age, but the recommendation starts only at 6 years, and they now went down with this to 3 years of age. But even younger children, as of 1 year, may be vaccinated if they are at increased risk to acquire TBE. Now, there is one peculiarity in Switzerland which I like very much and I fully endorse, in contrast to the license And in contrast to other TBE endemic European countries like Austria and Germany, Swiss authorities recommend since 2006 a 10-year booster interval after the primary vaccination, if the risk to acquire TBE virus infection persists. And this 10-year booster interval has been now confirmed. There is quite some body of data out there by now to show that the 10-year booster interval is sufficient. Now, the funny story about this, and this is why I like to tell, is when I was working with Pfizer, we tried to change the label and submitted the data to the licensing authorities in Europe and tell them less is equally effective. Use less of the TBE vaccine. The schedule for TBE vaccine is the most complicated of any vaccine in the world. Make it simple. Make it 2+1 plus a 10-year booster, or a 2+1 booster and another booster, and then a 10-year booster. Make it more simple. But they declined, and I think this is a sort of unique situation that a pharma company requested to lose less product, and it was declined by authorities. So the data, again, is very nice to show a 10-year booster interval is sufficient. It is recommended not only by Switzerland, but also, for example, in Finland. Melvin, as you live in Switzerland, what is your view here?
Well, I think it is really something that people visiting Switzerland, especially during the summer season, it's something that they should consider, because although the cases are not a lot if you compare to other diseases, this is a disease that most commonly really kills those who are infected, because they don't know that it's TBE, right? So they think they just have a headache, they just think that they're having flu, but in the end, when they go to the hospital, it's too late. TBE should TBE vaccine should really be considered by people who want to visit Switzerland, especially during the summer, because the disease really is something that's difficult for people to for doctors to diagnose. And although it's affecting few people every year, your chances of dying if you don't know that you have TBE is higher, right? So I think it's something that they should consider.
Yeah. And actually, it is individual protection only. If you're not measles vaccination, there's harm to others. Here, it's your own harm. You are the only one who is affected, and your health insurance company who has to pay for your severe disease, hospitalization, intensive care type thing, right?
Mhm.
Anyway, I think this is really good news from Switzerland. And I have one more vaccine piece, which is a very interesting study. And I have some background information summarized on this slide. And please read all the articles. It's really very nice story. The 23-valent pneumococcal polysaccharide vaccine is a pure polysaccharide vaccine with 23 sugars, capsular types of the pneumococcus. This vaccine was the first pneumococcal vaccine out there. It was licensed in the 1980s, and some decades ago, I was the one to recommend the vaccine when I was a member of the German NITEC, and I certainly did vaccinate my father with this vaccine. Now, the one question that was open is a second dose of this vaccine useful at all? And as a background information, any polysaccharide vaccine does not give you a T cell response, but a plain B cell response. The naive B cell picks up the antigen, and then there is a plasma cell which produces antibodies against the respective polysaccharide, against the respective capsule of the pneumococcus. There is no T cell response, and there's no memory cell. So you cannot booster because there is no memory cell. You can only revaccinate. You can give a second dose. And the question that is addressed then in the paper is if revaccination is useful. The value, again, has not been studied. What we do know that one dose of the pneumococcal conjugate vaccine has a modest effect. There is no effect 5 years after your vaccination, and there is no effect in the age group above 85. And the effect is, let's say, 60-70% at the most. It is mostly up to 50, 40, 50, maybe even 30% only to begin with. So it is not a very good vaccine, right? But it was the first one out there, and it was the only thing that was available for decades. Now, because there is no T cell response, this vaccine does not reduce carriage. Pneumococcal pneumonia is aspiration pneumonia. If the vaccine doesn't reduce carriage, that means the organism is still in your nasopharynx. You aspirate it and you get pneumonia. The vaccine cannot prevent pneumococcal pneumonia. It can only prevent invasive pneumococcal disease. Once you have pneumococcal pneumonia, the organism cannot make it into the bloodstream because antibodies in the bloodstream may kill the bacterium. So it's a funny vaccine. Again, the important point is this vaccine has no memory response and it does not reduce carriage. Now, but there was a double-blind randomized study in Japan in adult nursery homes, but this study lacks internal and external validity, and this is nicely summarized in this article down here by Gessner and colleagues. Again, this study, for whatever reason, is not valid. But still, it was considered by many NITECs around the globe, and this is why PPV23 was recommended. In one double-blind randomized study with the pneumococcal polysaccharide vaccine in HIV-positive adults, the vaccine doubled the risk to come down with IPD. With all these arguments, with the availability of pneumococcal conjugate vaccines, I see no reason at this point to use this vaccine anymore. But again, it was based on this Japanese study recommended in many countries around the globe. Now, the study that I wanted to show you with this background in mind, what is the value of re-vaccination? And what you see here is the survival, IPD, invasive pneumococcal disease survival in years from 0 to 14 years. The red line is the population who received one single dose of PPV23, and you see how they come down with invasive pneumococcal disease over time. And then there is the PPV23 revaccinated group. And what you see here is they come down with IPD more frequently. So the vaccine does not prevent invasive pneumococcal disease. It increases the risk of coming down with IPD. So revaccination with PPV23 is not a good idea. And along with this, I would also question for giving the vaccine just as a booster. If this is of any value, as now multivalent, 20-valent, and 15-valent pneumococcal conjugate vaccines are out there, and these vaccines reduce carriage, prevent pneumonia, and thus you're much better as a patient, you're much better off than with this PPV23. I'm sorry, this was a long story, but I think this is really, really interesting. I was waiting for this study for many years, and now it was published just recently. Melvin, any comments?
No, I think we should really look at the data, right? If this is now being shown that giving PPV23 is actually doing more harm than the expected benefit, then it's time for us to stop giving it.
Yeah. The one thing you may argue is this was not a double-blind randomized study, but it was population-based. It was well executed. Please read the paper. It is very, very interesting what they did to avoid confounders and what they did in terms of statistical methods to make sure that this is a valid set of data and a valid evaluation of the data. So it is a long paper, and I only show you one graph to make the point that you should read this paper. Melvin, having said this, you have some, you brought some funny here. What is the content
Well,
of this yellow talk?
not really funny, right? But it's just a reminder for everyone that when you see something online, I think we this came out during the pandemic, right? When all these misinformation and disinformation campaigns were just everywhere. But just to remind everyone that even though the pandemic is not a big deal anymore for people, we should still bear in mind that if you see anything online, you should really think before you share. Think
Yeah.
about who made it, what is the source, where did it come from, why are you sharing this, when was it published, and all these things. I think it's really good to remind all of us ourselves that we should think like this before we share.
And this is a WHO initiative?
Yes.
Ah,
United
okay.
Nations. WHO.
United Nations. Very nice. And with this, we come to the end. We talked today about WHO pandemic treaty talks end without a deal, but negotiations are ongoing. Melvin showed that antimicrobial resistance is an enormous and growing problem, and it is unevenly distributed around the globe and hits particularly the poor countries. Existing interventions can have a significant impact on low middle income countries. I spoke about nicotine fade out by date of birth as a new idea, or comparatively new idea to start smoking cessation. I showed you the new recommendations for TBE in Switzerland, and the old and good recommendation is that boosters are sufficient every 10 years. And then I spoke and I showed you the negative impact of PPV320 re-vaccination from population-based data from the United Kingdom. With this, thank you very much for listening. I am Joe Schmitt, and with me was Melvin Sanicas. Goodbye, Melvin.
Thank you, everyone, and stay safe.